Hello. 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 Hello, everyone. I hope I'm audible. We're going to begin our session shortly. Hello. We're going to begin our session shortly. Thank you all for joining in. I'm just going to wait for 1 more minute and we're going to start. So today's discussion will be strictly be focused on the basics of ECG interpretation and the localization of MI. I'll try to sum it up in one session. We have about 110 slides to cover. All right. So everyone has joined in, I see. So let me just begin. So today's topic of discussion is on the basics of ECG and localization of MI. From what I've learned in my internship here is that interpretation of ECG is very crucial in every department that you go. You frequently see ECGs being interpreted by your seniors, and it is my effort to just ease it for you guys because I've been very accustomed with seeing ECGs, studying ECGs, and reading from multiple books. So all of this session is going to be interpreted from the standard books that we have on ECG, whether it be the some of the books that I recommend for you for your further reading would be ECG Made Easy by John R. Hampton, a very good book. And if you want to go for something advanced, then there is a book known as Advanced ECG by Phibbs. So that's also a very nice read as well. For your video resources, I can recommend you guys to check out ECG Academy. So it's about 60 or 70 odd videos in which that person, that is Nicholas Turco, will talk on the basics of ECG as well as everything that you want to know about the interpretation of an ECG. So today's session will be mainly be focused. We're not going to cover rhythm disorders today. We're going to focus mainly on the different types of waves that we have, on the different types of intervals that we have. Then we're going to see some of the different patterns that we have on an ECG. And then we're going to conclude our session with the main thing, that is localization of MI. So today it's not going to be on a lecture of the management of MI because we are studying ECG in general, as well as for the other conditions as well. So let me just start. So before we go on about it, I need you to know something about atrial depolarization that happens. Okay. So as you can see over here, we have an SA node which is present over here. So what is the junction? What is the site of the SA node? It's at the junction of the right atrium and the superior vena cava. That's at the posterior superior wall of the right atrium, right? So whenever this SA node, which has this own automaticity, जब ये अपने potential generate करेगा, so these potentials from the SA node are going to travel downwards and to the left, right? So this is important for us. Okay. So if it is present in the right atrium and वो posterior superior wall पे अगर वो present है, the atrial depolarization जो wave है, that's going to sweep downwards and towards the left. And I want you to get accustomed with the internodal tracks as well. कि हमारे पास SA node है and we have the AB node. So SA node can send impulses to the AB node via these internodal tracks. So what are these internodal tracks that we have? We have three in number. We have anterior, that is Bachmann's bundle. We have the middle, that is Wenke bag, and then we have the posterior bundle, that is a Thorel's bundle. Okay. In some books, it has been mentioned that Bachmann's bundle is not technically the anterior internodal tract, but it's a branch of the anterior internodal tract. All right. So as soon as the atria have now become depolarized, so as you can see, all of the atrial muscles have been depolarized. So just remember, guys, whenever a muscle is completely depolarized, that is to say that every muscle is positively charged, then there is not going to be any net influx of ions that are going to exchange within them. मतलब यहाँ पे कोई भी wave नहीं होगी. it's going to be everything in the atria has been depolarized. So now the thing is, the only connection that is between the atria and the ventricles is the AV node, which is going to transmit the SC nodal impulses into the ventricles. But just remember one more thing, guys. As you know, atria is a syncytium on its own. The ventricles are a muscular syncytium on their own, as they're connected by gap junctions. But atria ki information to the ventricles cannot be directly transmitted. Why? Because as you all know, we have something known as the fibrous annulus over here. So this fibrous annulus will prevent any atrial impulses going to into the ventricles. Only they can go into the ventricles if they pass through this AV nodal tract, which is sometimes also known as the gatekeeper of the heart. So let's just see that. So now we're on to the AV nodal tract, guys. So just remember, AV nodal tract is highly specialized for slow conduction, and there are actually three reasons behind it. So what are those? First thing is the longitudinal arrangement of the cells. That is कि जो हमारे cells हैं in the AV node, उनका जो longitudinal axis है, this is the longitudinal axis. This is perpendicular to the direction of the current. So what will happen is, if I talk about this, if the longitudinal axis is perpendicular to the direction of the current, then that means more membranes have to be crossed for the atrial impulse to get conducted into the ventricles. So if more membranes have to be crossed, मतलब resistance भी ज़्यादा होएगी, and that is the reason why AV nodal impulse जो है on an ECG is very minimal. ठीक है? So that is the first reason behind it कि AV node इतना specialized क्यों है for slow conduction. The second reason is the scarcity of the gap junctions itself. Gap junctions खुद ही इतने कम है कि जो भी वो amplitude generate कर रहे हैं the AV node, that is it conducting at a very slow speed. And the third reason is the decreased resting membrane potential of your AV node. When I say the decreased resting membrane potential, I mean as a positive decrease. If it is minus 55, so maybe it is minus 40 millivolts or something like that. So this positive decrease will actually decrease the amount of potential that is for the calcium channels to open up. So these are the three reasons that is your AV node is specialized for your slow conduction. So अगर वो specialized है for slow conduction and उसके पास अगर कोई भी amplitude नहीं है, the thing is, guys, AV node is a very small tissue. First reason. The second reason is it has high resistance. Why is it high resistance? Because इसमें gap junctions भी कम है and इनका longitudinal axis is perpendicular to the direction of the current, as we saw. And that is the reason why on an ECG strip, AV node ka activation will not generate any positive or negative wave. So there is no positive or negative wave. There is a flat interval which are going to study it as the PR segment. Okay? So the AV nodal conduction is the electrical silence that we see on an ECG. So let's move forward now. So now from the AV node, we know that there is something known as the bundle of His. So this is the bundle of His, and this bundle of His later divides into the left bundle branch and your right bundle branch. Now these the bundle of His, or whether it be the left bundle branch or your right bundle branch, and even the terminal your Purkinje fibers are highly specialized for fast conduction. Okay? Why are they so highly specialized for fast conduction? We can apply the exact opposite rules that we studied in AV node. What are they? First thing, longitudinal axis of these cells. So this is the longitudinal axis is parallel to the direction of the current. So what would that mean? As you see, this amount of जितना हमारे ये जो membrane है, this is considerably less as we studied in the AV node, right? So there is going to be less amount of resistance that we encounter over here. The second reason being there is a high abundance of your gap junctions present, so it is very specialized for fast conduction. So there's going to be fast conduction in these cells, and the fastest conduction that you see is in the Purkinje cells. All right. So let's move forward now. So as we know, कि अभी तक हमारा impulse from the SC node it has traveled into the AV node via the internodal tracts. From the AV node, it has went into the bundle of His. From the bundle of His, now it is going into the left bundle branch and your right bundle branch. And now अभी हमें देखना है कि how will the ventricular myocardium be stimulated. So the first part of the ventricular myocardium to get stimulated is the septal myocardium. Okay? Just remember, guys, this is the septal myocardium. Okay? So if you talk about the interventricular septa, उसका जो ऊपर वाला portion है, that is the fibrous layer. Okay? It's electrically it's not able to conduct very freely. But the basal portion of your septal myocardium is your myocardium proper. Okay? It's not the fibrous layer, but it can conduct current through it. So what can happen is, if you see, the left bundle branch is going to supply the septal myocardium, and it supplies in which direction? It's going to supply it inferiorly, from left towards the right, and from down towards up. So that is the direction of your septal depolarization vector. So as you can see, this is the direction of the septal depolarization vector, and we know why is it so. Okay? But just remember, guys, because the septal depolarization vector is considerably small as compared to the major ventricular depolarization vector. Why? Because हमारे पास septum ही इतना कम है. Now let's move on to the next one. So we have the major ventricular depolarization. ठीक है? क्या हुआ? हमारे पास left bundle branch है. We have the right bundle branch. The left bundle branch will supply this myocardium. The right bundle branch will supply this myocardium. ठीक है? Because we know that the left ventricle is 3 times thicker as compared to the right ventricle, मतलब यहाँ का vector is going to be more positive in amplitude. ठीक है, as you can see vector की जो हम magnitude represent करते हैं, that is by the length of that vector. ठीक है, so the length of the left ventricular depolarization vector is more as compared to the right ventricular depolarization vector. So इसके कारण जो मेरा mean vector आएगा, ठीक है, that's going to be somewhere tilted towards the left. So where is it moving? It is moving from up towards down and towards the left hand side. Okay, very important. And if you see, when we see the myocardium, we have the subendocardial layer and then we have the subpericardial layer or the subepicardial layer. So the myocardium जो Purkinje fibers हैं, they're going to, the wave of depolarization is going to travel from the subendocardium toward the subpericardium. ठीक है, and this is the major ventricular depolarization vector का जो mean हमारा voltage है. So after all of this is done, in some books it is also said that the basal portions of the ventricle also undergo depolarization. So that is sometimes known as the basal ventricle. Hello? All right, so let's move forwards now. So what about the repolarization then? All right, so let's see. Repolarization ko concept here, guys, that the first portion of the myocardium that was to undergo depolarization, that will be the last to undergo repolarization. That's a simple dictum that we have to study. मतलब अगर the depolarization vector हमारे कहाँ से start हुआ था? It started from the subendocardial layer. It traveled toward the subepicardial layer. Now the subendocardial layer will be the last to undergo repolarization. So the repolarization vector will move from outward toward the center. Okay, major ventricular depolarization was in this direction because it's moving from inward to outwards, but the repolarization vector is going to be in this direction. Why? Because it's moving from outward towards inwards. So just remember, guys, here's a very short trick for you. So whenever we have if this is my a bipolar lead, so this is my negative potential, this is my positive lead, right? So whenever a ventricular depolarization vector is moving towards the positive electrode, so it's a depolarization vector, matlab I'm going to write positive in its head. So whenever a major ventricular depolarization vector, any depolarization vector moves toward the positive lead, I'm going to record a positive pole. If it is moving away from the positive lead, then I'm going to record a negative potential. But if I talk about the repolarization vector, the repolarization vector have a negative in its head. Matlab, if it is moving towards the positive lead, I'm going to see a negative potential. And if it is moving away from the positive lead, then I'm going to record a positive potential. So this is what is happening over here as well. What is that? Abhi we'll study that the direction of lead 2 is in this direction. That is 60 degrees, right? तो अभी हमारा जो ventricular repolarization vector है, it is from outward towards inwards. हमने पढ़ लिया. ऐसे same for the vector concept we can say this is your right ventricular repolarization vector, this is your left ventricular repolarization vector. Because the left ventricular is more thicker, this is going to be my mean repolarization vector of the myocardium. So this negative is moving away from the positive head. So we are going to record a positive potential in especially in lead 2. So the repolarization, that is your T wave, I'm going to say, that's going to signify your ventricular repolarization. That's going to be a positive potential. Okay, so that is the concept. And what is the reason why that the subendocardial layer is the last to undergo repolarization is the simple. There are two reasons behind it. The first reason being the subendocardial crunch. What do I mean by that? So whenever the myocardium contracts, it's going to contract from outward towards inwards. Okay, outward से inwards की तरफ वो contract करेगा. So it's going to occlude the subendocardial blood supply. और इसके कारण the repolarization is going to be hindered in the subendocardial layer. So that is the first reason. The second reason is कि जो subendocardial layer subendocardial layer का जो action potential है उसकी duration is more as compared to the epicardial action potential. So I can say the relative brevity of the epicardial action potential is responsible for its earlier repolarization as compared to the subendocardial potential. Alright, so this is summed up, guys. So this is the atrial depolarization vector moving from the right hand side toward the left hand side and from upwards toward downwards. That's the first one. Then we're going to have the AV nodal silence due to the AV nodal tissue. Then we're going to have the septal depolarization vector, which is going to move from the left towards the right and from down towards up, right? Then we have the major ventricular depolarization vector, which is going to move downwards and leftwards. And sometimes we also represent the basal ventricular depolarization vector. Again, it is from upwards, from downwards towards up and towards the right hand side. So if I take a normal, if this is my lead 2, if this is my axis of lead 2, so this is my positive and this is my negative, this is my lead 2 I am drawing. So lead 2 mein, as you can guys see, अगर हमारा atrial depolarization vector, it has a positive in its head, so the depolarization vector is moving towards the positive potential. I'm going to record a positive electrode, positive potential. That's a P wave. Then I'm going to see an AV nodal silence. So that is being represented over here in the form of the PR segment. Then if you see the Q wave, so the septal depolarization vector is moving away from the positive electrode of your lead tube. So what's going to happen? I'm going to record a negative potential. So this is the negative potential of the Q wave. What about the R wave then? The R wave with the major ventricular depolarization, it's moving towards lead tube, a positive electrode, and I'm going to see a positive deflection of the potential. And what about the S wave now? The S wave might represent the basal ventricular depolarization vector, and it's moving away from the positive electrode. And again, I'm going to see a negative deflection. So that is summed up for you guys. Just remember guys कि SG segment जो है ना, that is that portion of the cardiac cycle जहाँ पे हमारा ventricle is completely depolarized. So whenever something is completely depolarized, मतलब सबके सब positive है, then there is not going to be any influx or there is not going to be any change in the basically flow current. Basically हमारा flow नहीं करेगा because एक positive है दूसरा positive है, so there is no flow of current over here, and I'm going to see an isoelectric line over here just like the PR segment. But the PR segment ka isoelectric line was mainly due to the AV nodal silence, and the ST segment ka isoelectric line is mainly due to the fact that all of the ventricle is depolarized. So let's just see, this is the correlation between your electrical events in the myocardium that is happening with the electrical events plotted on the ECG. Can you see? So this is the ventricular myocardium. This is the ventricular myocardium ka action potential I'm drawing over here, and this is my ECG. I know that during the QRS portion, the ventricle will undergo depolarization. That's true. It's undergoing depolarization. But what about the ST segment? ST segment is more or less isoelectric, right? We talked about this. How is it isoelectric? If you see about the action potential, if you see when we draw an action potential of a fast action potential in the myocardium, so what are its basic? उसके कौन से stages होते हैं? So we have phase 0, that is the rapid ventricular depolarization. Then we have initial depolarization. Then we are going to have the isoelectric, that is a plateau stage. So the ST segment is going to correspond with the plateau stage in which the ventricles are completely depolarized. And it should make sense as well, because during the plateau stage, I'm going to have a tremendous amount of calcium coming in, and that calcium will be required for your ventricular contraction. So that is the reason. All right, so let's talk about the ECG paper now. So ECG paper, if you see, so we are going to study something about it. The first thing is, whenever we want to interpret an ECG, we should talk about the standardization first of all. So what is the standardization? What is the speed of the ECG at which it's running? जो हम standardization use करते हैं, that's about 25 millimeters per second. Okay, so this is for your intervals of your time. What about the amplitude then? Amplitude is 10 millimeters. That is, this small box is 1 millimeter. Okay, so 10 millimeter is going to be 1 millivolt. So that is the amplitude ka, that is the amplitude ka your standardization. So let's just look over here. So what are the timing and duration of the ECG wave segments and intervals when you plot on an ECG paper? So what is that? So during 1 minute, I'm going to see. Abhi I saw that the 25 millimeters per second se mera speed chal raha of the ECG paper. That is standardization, normal standardization. So during 1 minute, it's going to have 300 big squares. So what is this big square and all of this? Okay. So just remember that 25 millimeters per. All right. I'm sorry, guys. I'm back right now. So there is some problem with the connection. Thank you for bearing. Okay, so अभी हम आगे start करते हैं. So where we left off, right? तो अभी we were talking about the ECG strips, right? कि हम standardization की बात कर रहे थे. So the speed is 25 millimeters per second. Okay, one small square is 1 millimeter. Just remember, and one big square is made up of 5 small squares, so it is going to be 5 millimeters. ठीक है? So अगर मैं 25 millimeters per second की speed से run कर रहा हूँ, so that would mean 1500 small squares are getting crossed. ठीक है? During 1 minute, 1500 small squares are getting crossed, and during 1 minute, what's going to happen is, am I audible? Can someone please respond? So there is some problem with the connection over here. I think I'm audible. So let me just continue. Thank you so much. Okay, so we were talking about the standardization. तो अभी हमने देखा 1 minute में 1500 small squares are getting crossed, and 1 minute में, if you see, 25 millimeters per second की speed है, so I can say it's about 5 big squares are getting crossed in 1 second. So it's going to make up about 300 big squares that is getting crossed in 1 minute. So that is the standardization. और अगर मैं इसे equate करूँ, right? So one big square, if it is 5 small squares, one small square is going to be 0.04 seconds. Okay, so it's 40 milliseconds का मेरा एक small square है, and one big square is 5 times that. That is 200 milliseconds का मेरा एक big square है. ठीक है? So it's 0.2 seconds or 200 milliseconds, and we're going to have 40 milliseconds. Thank you so much, Shivangi. Okay, so let me just continue. So let's just talk about the ECG leads now. Okay, so let's just see how are the ECG leads placed, and we're going to discuss some of the history of the ECG as well. So this is what I want you to know, and I want you to learn by heart. This is going to be a very practical based thing. So just remember, guys, actually हमारे पास जो ECG machines हैं, they're actually of two types. ठीक है, हर ECG machine में you might see some of them will have ECG जो भी leads placement होती है, that is somewhat different as compared to other machines. So why is that happening is कि जो हमारा जो basic, there are two bodies which regulate and make ECGs जो भी standardized bodies हैं. One is the American Heart Association and one is your International Electrotechnical Commission. ठीक है, most of the ECG machines are according to the International Electrotechnical Commission. Okay, and this is what I want you to remember. If there is some discrepancy, you can always see हमारी जो भी ECG machine होती है वहाँ पे हमेशा लिखा होता है what is the correct lead placement. So just corroborate with that as well. ठीक है, so let's just see about the International Electrotechnical Commission क्या कहती है. So it just says, it's very easy to remember. Just remember, right arm is red. Okay, so when you remember the right arm is red, I want you to imagine a traffic light. Okay, so this is the person. I'm going to draw a person over here, and this is my right arm, this is my left arm, this is my left leg, and this is my right leg. So what I want you to see, this is red. Okay, the right arm is red, R stands for right, so it's going to be red. I want you to imagine in a clockwise direction the colors of a basic traffic light. Okay, so if right arm is red, then what is after that? It's going to be yellow. So the left arm is going to be yellow. Okay, and what about the left leg then? The left leg is obviously going to be green. And just remember, foreground, I want you to say that it's black. Hamisha. Okay? It's going to be black. You can see in the different circuits that we have, Hamisha, black stands for your ground. So this is what I want you to remember. Okay? About the precordial chest leads, I don't actually want you to remember that. You can place it according to the machine. Okay? जो भी उसमें दिया होता है. All right. So let's just talk about the leads now. So the first lead that we have is the bipolar limb lead. So why am I calling this as bipolar is it's going to have two electrodes. One is going to be a positive electrode, one is going to be a negative electrode. So that is the meaning behind it. It's a bipolar limb lead. So why were they known as limb leads? Because it was given by Einthoven, and Einthoven ने जब भी first experiment किया था on your recording ECGs, he did it in a bucket filled with normal saline. ठीक है, उसने saline filled conductors लिए, saline filled उसने buckets लिए, and he immersed the whole limb into it to record your first ECG strip. ठीक है, so according and he attached it to a galvanometer, that is to electrode, जितना भी हमारा potential आ रहा है उसको record करने के लिए. So this is why it is known as a limb lead. ठीक है, so just remember guys, हर limb lead के पास एक negative electrode है, एक positive electrode है. ठीक है, from negative to positive, this is known as the axis of your lead. So this is the axis of the lead. Negative से positive, if I'm going to draw a straight line, that's going to be axis of the lead. If you remember guys, if the depolarization vector is moving towards the positive electrode, it's going to have a positive deflection. If it is moving away from the negative, positive electrode, it's going to have a negative deflection, right? And if it is moving perpendicular to it, and this is going to be very important for us in determining axis. If it is perpendicular to it, I'm going to see a biphasic deflection. So it's going to be initially positive and then it's going to become negative. So that's a biphasic deflection. Why is it so important for us? इसके through I can determine the ECG. I can see क्या मुझे कोई ऐसा QRS दिख रहा है which is biphasic. If I see that, then my axis is going to be perpendicular towards it, going to add either 90 or deduct 90. तो वो हमारी axis होगी. ठीक है? That's your mean axis. So just remember guys, हमारे पास दो leads हैं. अभी we are discussing the bipolar limb leads. So what are these limb leads? These limb leads are going to record, they're going to have record your potential in a frontal plane. ठीक है? As we all know, हमने anatomy पढ़ी है, we know what is a frontal plane. So it's going to record your direction in the frontal plane. So these are the different the vectors that we represented as well. So this is the septal depolarization vector, this is your major ventricular depolarization vector, and this is your basal ventricular depolarization vector. ठीक है? And हमने ये भी पढ़ लिया that we can have different components along different leads as well. For example, अगर मैं इस lead की बात करूँ, this is lead 1, right? We're going to see it shortly. And this is my any QRS potential. ठीक है? This is my QRS deflection over here. I can say कि इसका दो components है मेरे पास. One component of it is along your lead 1. The second component might be along your lead 3. The third component might be along your lead 2. Right? So just like a normal, जब हम vectors पढ़ते हैं उसके accordingly and angles के accordingly, we can have different amount of amplitude of the R wave as well. ठीक है? So you might be figuring it out. Why is this arrangement of the leads? ठीक है, Einthoven ने ऐसा ही क्यों arrange किया? Why did he want the right arm to be completely negative? Why did he want the left leg to be completely positive? So the thing is, and the short answer is, because उसका मन किया. The thing is, Einthoven wanted the major ventricular depolarization vector CARB to be positive. He wanted it to be positive. So he arranged the leads in this fashion कि मेरा जो main QRS है वो हमेशा positive आए. वरना हमें क्या करना पड़ता है? We are not as humans we want something to be very positive. ठीक है? So Einthoven arranged them because he wanted the QRS to be positive. ठीक है? To facilitate the positive deflection due to the major ventricular depolarization that is directed leftwards and downwards, the positive electrode has to be placed either on the left arm or on the left leg. So that is important for us. We have not mentioned the right arm because अगर हम right arm को mention करने लग जाएंगे, then the QRS mean will be negative. And you can remember that is the reason why right arm is always negative. ठीक है? Right arm में it's always negative and the left leg is always positive. ठीक है? Always positive. The left arm actually depends. Okay? If it is in relation to the left leg, it's going to be negative, and if it is in relation to the right arm, it's going to be positive. Okay? So let's just see that. So lead 2 guys is going to have the maximum amplitude. Why is that? Because मेरा जो major ventricular depolarization vector है ना, उसका अगर हम QRS का mean लेते हैं, which is in physiology books, it comes out to be 59 degrees. And मेरा जो lead 2 का जो axis है, that is 60 degrees. And that is the reason why lead 2 will show the maximum amplitude. Okay? And now we're going to move on to something known as the Einthoven's triangle. So what is this Einthoven's triangle? Einthoven's triangle is, it's an equilateral triangle around the heart, lead 1, lead 2, lead 3 forming its side. Okay? So let's just study what is that. So according to Einthoven's law, lead 1 plus lead 3 always equals lead 2. And this is the rationale behind it. You can go it in great detail. I've already shared the PDF in the Telegram group as well. So you can join in and just see over it as well. So let me just tell you some gist of it. The main thing is it's a volume conductor. Hamara heart and our body is a volume conductor. So the simple physics ka jo formula hai, that is, if there is a volume conductor and it has a current I in the center, there is a current I in the center, and I'm recording potentials at 3 points of an equilateral triangle with a current in the center. You know what will be the sum if I put together all of these potentials together? It's going to be 0. So that is the thing. In a volume conductor, the sum of the potentials at the vertices of an equilateral triangle with a current source in the center is 0 at all times. And this is the basis of the Einthoven's law. So you can just see how I have actually derived this equation. So you can come on to the simple fact that is your lead 1 plus lead 3 is equal to your lead 2. And even if you look at Kirchhoff's as well, हमने Kirchhoff's पढ़ा था in 11th and 12th physics. So according to Kirchhoff, the algebraic sum of every voltage in a given loop has to be 0. So it's like this, कि अगर lead 1 है and lead 3 है, minus your lead 2 because it's in the opposite direction. ठीक है? Or I can say lead 1 plus lead 3 plus minus of lead 2 is going to be 0. And that is the reason why lead 1 plus lead 3 is again equaling to lead 2. So that is again 2 reasons why this is so, कि lead 1 plus lead 3 is your lead 2. But क्यों याद करना है हमें basic? I'll tell you one thing, okay? Most of the ECG जो हमारी machines हैं, they always tell you about the lead misplacement. बता देती हैं वो, ठीक है? Sometimes you have also seen कि हमसे भी कई बारी lead misplacement हो सकती है, and nurses से भी lead misplacement हो सकती है. And sometimes what you want to do, just try it on your, एक बार just try करना, ठीक है? I want you to look at every ECG strip that you have, whether it be in the ward. ठीक है? एक चीज करना जरूर. Apply the Einthoven's law onto it. What did I say? Lead 1 plus lead 3 equals lead 2. You know what is the main basis of this? The main basis is problem आती है हमेशा with your limb leads. ठीक है? उन्हीं का misplacement is dangerous और उसके कारण हमें lead misplacement मिलता है. वरना तो patient को dextrocardia हो जाएगा, है ना? That can be one possibility. So just add lead 1 and lead 3. It should come to lead 2. When I say add, I mean the mean add. कि ऐसा हो सकता है कि lead 2 might be predominantly negative. ठीक है? तो ऐसा करना है कि उसका एक मीन लेके उसे ऐड करना है. एंड आई विल टेल यू गाइस दिस फॉर्मूला विल वर्क एवरीवेयर. ठीक है? एंड आई हैव ऑलरेडी करेक्टेड कि एक बार नर्स को भी डांट पड़ने वाली थी, एंड आई टोल्ड द सिस्टर कि एक बार फिर से करा लो, ये लीड मिसप्लेसमेंट है, इसमें शो नहीं हुआ है ड्यू टू सम रीजन इट डिडंट शो. और मैंने एक बार ये हमेशा आई ट्राइड टू एवरीवन, आई टीच इट टू एवरीवन कि जस्ट ऐड लीड 1 एंड लीड 3 शुड कम टू लीड 2, एंड आई मीन बाय द मीन QRS. Okay. So this is the triaxial reference system if I talk about the bipolar limb leads. So let's just see that. ठीक है? तो how are they placed over here? तो मेरा negative electrode is present on the right arm. The positive electrode is present on the left arm. This is going to make my lead 1. So this is lead 1. So if you talk about the axis of the lead, it's at 0 degrees. That's the first lead that I'm going to talk about. The second lead is lead 2. Where is that? The right arm पे मेरा negative है and left leg पे मेरा positive है. So this is my lead 2. What is the axis of the lead? It is at 60 degrees. And lead 3, what about that? The lead 3 is I have left arm pe negative, just remember, and left leg pe it is positive. This is my lead 3. What is the axis? It's 120 degrees. So lead 1 ke liye 0 degrees, lead 2 ke liye 60 degrees, and lead 3 ke liye 120 degrees. And just remember guys, it's measuring all of these potentials in the frontal plane. Okay, it's a frontal plane section. It's like this, it will take like a frontal plane through the body. So let's talk about the unipolar chest leads now. So unipolar chest leads, actually जो उसका concept था, that was first given by Wilson. Okay, Einthoven gave the limb leads, Wilson is going to give the unipolar chest leads. So what are these chest leads going to do? It's going to take a horizontal section through the heart. It's going to slice it like this. Horizontal section लेंगे through the heart, and we're going to see the different potential that is occurring through it. Okay. The thing is, the catch is it's unipolar. मतलब it's going to have only one electrode जिसे मैं ना positive कहूँगा ना negative कहूँगा. It's going to be an exploring electrode, or sometimes ठीक है, it's an exploring electrode. So you might ask, यार हर चीज तो एक potential difference के comparison में होता है. So ऐसा तो है नहीं है, there's only a single electrode for your unipolar chest lead. The thing is guys, it's a single electrode superficially. मतलब उसके अगर तुम देखोगे, अगर तुम प्रिकॉर्डियल चेस्ट लीड्स अगर रिकॉर्ड करते हो, इट्स अ सिंगल बलून शेप सा जो होता है विच यू अटैच टू द पेशेंट्स बॉडी, है ना, सक्शन सिस्टम होता है. इट्स अ सिंगल इलेक्ट्रोड. बट ऐसा नहीं है कि वो पोटेंशियल जो है दैट इज a single it is only working on the principle of a single electrode. The main thing is we have created something which is known as the indifferent electrode. ठीक है, that's known as an indifferent electrode which is placed at the center of the heart. And you might be thinking, अरे ये क्या invisibly हमने कोई electrode place कर दिया in the center of the heart? That is not so. हम एक potential generate करेंगे which is going to come towards zero, and उस potential का sum we can arbitrarily say that it's in reference to the center point of the heart. उस पोर्शन को हम क्या कहते हैं? That's known as the common terminal. So what is that? To create an indifferent electrode जिसके थ्रू मैं comparison make कर सकूं via this exploring electrode, I'm going to draw an indifferent electrode. How am I going to do that? मैं सारे portions को right arm, left leg को तीनों को galvanometer से attach कर दूंगा. But just remember, I'm going to attach a very high resistance to it. What's going to happen? ये मेरा voltage है, ठीक है, इसके थ्रू कुछ current flow कर रहा है. It's going to suffer some voltage drop. As you know, voltage drop का formula guys, that's IR, है ना. So the voltage that is going to come over here is V minus IR. So इतना IR इतना बड़ा है that this V comes out to be 0. ठीक है, so this comes out to be 0, this comes out to be 0, this comes out to be 0. And if I'm going to make a mean of it, that is कि right arm का mean लेके, left arm का mean लेके, and left leg का mean लेके, and I'm going to divide it by 3, all of this comes out to be 0. So that is an indifferent electrode. And as you can see, अगर right arm, left arm और मेरा left leg है Einthoven's law के accordingly, the current is originating in the center, right? तो मतलब मेरा जो indifferent electrode है इन तीनों को sum करके, it must be lying at the center of the heart. So that is the principle of your unipolar chest leads. So let's just see. तो Wilson ने क्या किया? He created a central terminal. ठीक है? So you can read through it. If the vertices of the triangle are added up together, they almost record a value of your 0. This average of potential at each limb is thought to represent a common terminal, which can be linked off or thinked of as an indifferent electrode. So this is the thing. The VCT, ये मेरा voltage drop है, and this is VRA minus IRA into 5000. So इसने जो resistance use किया था Wilson ने, that was 5000 ohm. इतना ज़्यादा उसने resistance use किया so that this IR is going to overshadow your VRA, and इन तीनों का sum, ठीक है, और algebraic sum is going to be 0. ठीक है. So this is the potential that is going to be measured by your exploring electrode. What is that? कि the exploring electrode का जो EMF है minus your VCT that is lying in the center of the heart, which is almost equivalent to your 0. So that is the thing of your Wilson chest lead. तो अब हमने इससे क्या कर दिया? अगर मेरा central terminal in the center of the heart है, मैं कहीं पे भी electrode रख दूं, I'm going to record something जो कि उसकी direction में है. The indifferent electrode lies in the center. So whatever positive or negative it's moving through, that is going to be recorded by the exploring electrode. Okay. So how do I place the placement of the chest lead? So let's just discuss that. So we have V1, that's in the fourth intercostal space on the right side of the sternum. We have V2, that's in the left side of the sternum, fourth intercostal space again. Now place V4. First V4 क्या है? V4 is an imaginary V4 क्या है? Basically it's lying in the mid clavicular line, fifth intercostal space. ठीक है? Mid clavicular line में fifth intercostal space में हमारा V4 है. So V3 is going to lie between V2 and V4. ठीक है? V2 और V4 के बीच में your V3 is going to lie. What about V5 then? V5 is going to lie in the anterior axillary line in the fifth intercostal space again, and your V6, last wala, is your mid axillary line में again in the same plane, that is your fifth intercostal space. So let me just revise. V1, right side of the sternum, fourth intercostal space. V2, left side of the sternum, fourth intercostal space. Then we place see the V4. What is V4? V4 is lying in the mid clavicular line, fifth intercostal space, left वाली, ठीक है. Now V3 कहाँ होगी? It is somewhere between V2 and V4. V5 is in the anterior axillary line, ठीक है, left anterior axillary line, fifth intercostal space, and then V6 in the mid axillary line, again in the left intercostal space, fifth intercostal space, ठीक है. Just remember, guys, always compare it with your that is sternomanubrial angle, जो हमारा basically manubrial sternal angle. Why is it that so? Because position of the nipple that we arbitrarily use at the fourth intercostal space, that can be variable. So that is not used as a landmark for the placement of your chest leads. Okay, if you want it to be done it in a very standardized manner. So let's just talk about the orientation of the chest leads now. So I'm going to discuss only the functional aspect of it. If you remember, guys, एक चीज conceptual चीज है. Whenever I'm going to talk about the chest leads, they're not going to record directions in superior inferior fashion. Okay, it's a section through the heart, है ना? Section through the heart that's only going to be left and right. So whatever, जो भी है मेरा septal depolarization vector हो, that was moving from the left towards right ना, and it was moving from where? It was moving from inferior to superior. But when I draw the chest leads, मेरा superior inferior aspect is not recorded. So I'm going to draw it as only left to right. What about the major ventricular depolarization vector? That's going to be towards right to left and not from upwards to downwards. Okay? Functionally speaking, V1 and V2 are your septal leads, V3 and V4 are your anterior wall leads, and V5 and V6 are your lateral wall leads. Okay? So let's just talk about the next thing in line. Then we have something known as the augmented limb leads. Okay? So this augmented limb leads was given by a chap known as Goldberger. So this Goldberger guy, what he wanted was कि मुझे limb leads create करनी है which is somewhat augmented. ठीक है? How did he do that was, उसने भी विल्सन का ही कॉन्सेप्ट लिया, उसने भी सेंट्रल टर्मिनल क्रिएट किया. बट ही सेड इफ आई वांट टू ऑगमेंट द राइट आर्म का लीड, सो व्हाट इज दैट नोन एज? दैट इज नोन एज ऑगमेंटेड एवीआर. ठीक है, ऑगमेंटेड राइट आर्म लीड. ठीक है, एवीआर. अगर उसने वो एवीआर क्रिएट करना है, व्हाट विल ही डू इज, विल्सन ने क्या किया था, उसने तीनों को कनेक्ट करके ही कनेक्टेड इट टू द सेंट्रल टर्मिनल, उससे रिकॉर्ड किया. बट गोल्डबर्गर ने कहा इसके कारण तुम्हें थोड़ा सा जो पोटेंशियल है वो कम मिल सकता है. व्हाट ही सेड वाज स्पेयर दैट लीड. स्पेयर दैट लीड जहां पे आप अपना एक्सप्लोरिंग इलेक्ट्रोड लगा रहे हो. ठीक है, सो दिस में एक्सप्लोरिंग इलेक्ट्रोड मतलब यहाँ मेरा इंडिफरेंट इलेक्ट्रोड यहाँ पे मेरा नहीं क्रिएट होएगा. तो मैं लेफ्ट आर्म से लूंगा एंड मैं लेफ्ट लेग से लूंगा, दोनों को अटैच करूंगा टू 5000 ओम का रेजिस्टेंस, क्रिएट अ VCT एंड देन कंपेयर इट विद योर राइट आर्म. एंड इसके कारण मुझे क्या पोटेंशियल मिलेगा? आई एम गोइंग टू गेट एवीआर. एंड द सेम स्टोरी आई कैन कंटिन्यू ऑन एंड ऑन. What about AVL? तो AVL में उसने क्या किया? एक्सप्लोरिंग इलेक्ट्रोड लेफ्ट आर्म पे कनेक्ट किया एंड ही कनेक्टेड द सेंट्रल टर्मिनल के जो उसने क्रिएशन किया, दैट वाज बाय द राइट आर्म एंड योर लेफ्ट लेग, and he connected to the galvanometer and he recorded the potential to be as AVL. And the same goes for your AVF as well. ठीक है, AVF में exploring electrode was placed on the left leg and यहाँ पे उसने indifferent electrode की lead नहीं attach की, which are represented by black. Indifferent electrode की कहाँ attach की? On the right arm and the left arm. दोनों को voltage drop से compare किया and he created again the ventrals, the voltage at the central terminal. ठीक है, so why do we call them as augmented? Just see the derivation behind it. Due to shortage of time, we won't be able to discuss it. But just remember, it all checks out the potential कितना augment हुआ as you compare to the AVR. If I say AVR है एक at one hand and I have voltage in the right arm at one hand, how much is it augmented? I want you to remember, guys, AVR is equal to 1.5 times of your voltage that is recording in the right arm. So it's a 1.5 times multiplication. Okay, it's a 1.5 times greater than the potential of that specific lead, and that is the reason why I'm going to call it as augmented limb leads. And you can check this derivation out and see it on your own, right? ठीक है, so this is the hexaxial system now, guys. हमने देख लिया chest leads पर recording electrode, recording potentials in the horizontal plane. We have discussed the limb leads. लिम लीड्स में से हमने एक बाइपोलर लिम लीड्स देखा, दे वर अगेन रिकॉर्डिंग इन द फ्रंटल प्लेन, एंड हमने अभी ऑगमेंटेड लिम लीड्स देख लिया व्हिच इज अगेन रिकॉर्डिंग इन द फ्रंटल प्लेन. सो नाउ इट्स गोइंग टू बी एन हेक्साक्सियल सिस्टम, मतलब इट्स अ 6 लीड सिस्टम. व्हाट इज दैट? लीड 1 इज अगेन 0 degrees, लीड 2 इज 60 degrees, लीड 3 इज 120 degrees. एंड यू कैन सी बाइपोलर लिम लीड्स जो हमारी आई ऑलवेज आई एम गोइंग टू ड्रॉ एज नेगेटिव एंड पॉजिटिव. ठीक है, नेगेटिव एंड पॉजिटिव बिकॉज दे आर बाइपोलर लिम लीड्स. बट व्हाट अबाउट द ऑगमेंटेड लिम लीड जो अभी मैंने क्रिएट किए? इफ आई एम गोइंग टू ड्रॉ द AVR, कैसे ड्रॉ करूंगा मैं? आई एम गोइंग टू ड्रॉ इट फ्रॉम द सेंटर ऑफ द हार्ट, दैट इज माय VCT, दैट इज वोल्टेज इज द सेंट्रल टर्मिनल, एंड आई एम गोइंग टू ड्रॉ टुवर्ड्स दैट इज AVR जो है दैट इज एट -150 degrees, AVL इज एट -30 degrees, and my AVF is at +90 degrees. ठीक है, and it's only going to have an exploring electrode, तो मेरा axis जो है it's going to run from the center of the heart outwards toward that specific limb. ठीक है, so ये मेरा हो जाएगा hexaxial system. All right. So there are some specific lead modifications, guys. अभी तो हमने basic place कर ली, हमने limb leads place कर ली according to the International Electrotechnical Commission, and we have already placed the chest leads as well. So that is easy job for us. Now some थोड़ी सी इसकी modifications हैं, guys. If you remember, guys, medicine में for all my juniors who is watching, they will read it in medicine, and who is in internship year or who is in final year or pre-final year, he must be remembering something known as the treadmill test. That is TMT बहुत करवाते हैं, right? If anyone is a patient of angina, what do you call him? Angina उसे हुआ, and now he's coming to the hospital. Now he's not going to have any changes in the ECG, right? So हम क्या करते हैं? We conduct a stress ECG. That can be done either via bicycle test or via treadmill test. That's known as the TMT. If you remember, guys, अगर treadmill पे patient भागेगा, ठीक है, और ही रन्स ऑन अ स्पेसिफिक स्लोप, ठीक है, दैट इज अकॉर्डिंग टू ब्रूस प्रोटोकॉल. तो डोंट यू थिंक अगर हम ये लिम लीड्स यहाँ पे लगा रहे हैं जस्ट एट द रिस्ट पे जो हम हमारी लिम लीड्स लगा रहे हैं, व्हेन ही मूव ऐसा नहीं होगा कि वो थोड़ा सा इंपीडेंस क्रिएट कर सकती हैं. दैट इज व्हाई मेसन लिकार मॉडिफिकेशन वाज डन. मेसन लिकार मॉडिफिकेशन सेज कि इंस्टेड ऑफ प्लेसिंग द राइट आर्म एट द राइट रिस्ट और द लेफ्ट आर्म एट द लेफ्ट रिस्ट और द लेफ्ट लेग इवन एट द फुट, what you can do is आप थोड़ा सा मॉडिफाई कर सकते हो. हाउ? राइट आर्म को आप इंफ्राक्लाविकुलरली प्लेस कर दो ऑन द राइट साइड, लेफ्ट आर्म को आप इंफ्राक्लाविकुलरली प्लेस कर दो ऑन द लेफ्ट साइड, एंड लेफ्ट लेग को यू कैन प्लेस इट अलोंग द मिड एक्सिलरी लाइन between the lower rib and your iliac crest. Okay, between the lower ribs and your iliac crest you can place your left leg. So this is the Mason-Licar modification. And where am I going to do this? I'm going to do it when I'm conducting a treadmill test. Treadmill test में भी I'm going to see a stress ECG being done, because इसमें जो मेरे movements हैं, that's going to interfere during the test to the patient, right? So this is the Mason-Licar modification. We have some other ones as well. We have EASI system as well. ठीक है, EASI system. EASI जो lead system है, it's going to use 5 electrodes. ठीक है, as you can see different हमारी placed हैं. We can have E, that is at the lower end of the body of the sternum. ये मेरी body of the sternum के lower end पे है. Then A and I. This is A, this is I. A and I are placed in the left and right mixed axillary lines in the same horizontal plane as your E. Okay, so this is A, this is I, this is E. Where is S being placed? S is placed on the manubrium sterni. So this is my EASI system. Why is this so important? कभी भी guys, if you go to a CICU or if you go to a medical ICU as well, तो वहाँ पे जो भी हमारी monitoring हम करते हैं, we mainly do it by lead 2 and V1. ठीक है? So what can happen in lead 2 and V1 is some of the ischemic episodes can be missed by 2 lead monitoring जब lead 2 and V1 में हम कर रहे हैं. So we can use this EASI system in a highly risk prone patient कि उसमें ischemic episodes miss ना हो जाएं during your monitoring. So this is for your EASI system for monitoring. What else? We can have something known as the Lewis leads being placed. So you don't need to remember all of it. Just remember, guys, Lewis lead हमने कहाँ पे place करनी है? Right arm का जो electrode है, it's placed on the patient's manubrium, and my left leg का potential is going to placed at the right costal margin. So if you remember, right arm से left leg, what was that lead known as? So मेरा right arm ये है, मेरा left leg ये है. So wasn't this my lead 2? It was my lead 2. पर मैंने lead 2 की direction अब यूं कर दी है. Why the heck have I done that? It's a simple reason, बहुत simple है. What is that? It's going to monitor your atrial arrhythmias and detect them better. Okay? So atrial arrhythmias, when I want to record them in a better way, I'm going to use the Lewis lead. Right arm is present at the manubrium sterni and your left leg is present at the right costal margin. Now, the last modification that we have is the Fontaine modification. That is for your detection of your epsilon waves. We don't need to know the detail behind it. This is only for your MCQ purposes. Epsilon waves, as you guys know, where are they present? They're present in your arrhythmogenic right ventricular cardiomyopathy, that is ARVC. वहाँ पे you're going to see something known as the epsilon wave being detected over here. So you can see over here, है ना? ये हमारी epsilon wave present है, ठीक है? So if you remember, guys, arrhythmogenic right ventricular cardiomyopathy में क्या होता है? There is fatty infiltration of the right ventricle, ठीक है? Predominantly. Now they say that left ventricle is also getting involved, but right ventricle में there is fatty infiltration. उसके कारण क्या मिलेगा मुझे? I'm going to see T wave invasion in the right leads. That is V1 से V3 में I'm going to see T wave inversion. Can I see that? I'm going to see epsilon waves, right? That is due to a RV conduction delay. I'm going to see this positive abnormal wave that's known as a epsilon wave. QRS widening is only restricted to the right ventricular leads. That is V1 to V3. I'm going to see localized QRS widening. Okay? So this is my arrhythmogenic right ventricular cardiomyopathy. So this is the Fontaine lead modification. You can check that out as well. Okay? So let's just talk about the normal ECG as well. तो अभी हमने देखा different leads, हमने different waves देखी. We talk about the P wave. ठीक है, अभी we're going to discuss now. This is a normal ECG interpretation, how it should begin like. ठीक है, so these are the different checkpoints that you have to look at whenever you're looking at an ECG. So the first thing, the foremost thing that you have to see, very important, is the rhythm. Always check the rhythm first. And what is the rhythm ke liye? I'm going to use lead 2 as the best one. So lead 2 ke liye rhythm, I'm going to use the lead 2. What about the rate? Rate I'm going to use again lead 2 again. So rate ke liye bhi I'm going to see the lead 2. Then I'm going to check the different intervals that I have. I'm going to check the PR interval. I'm going to check the QRS duration. I'm going to check the QT interval, right? All of these stuff I'm going to do. What next? I'm going to see whether there is any chamber enlargement or not. क्या कोई left atrial enlargement तो नहीं है? क्या कोई right atrial enlargement तो नहीं है? Right? Anything like that? Is there any blocks or is there any QRST changes? So this is the sequence that I want you to go by. The main thing is always check the rhythm and the rate first. So what is rhythm? When I say a normal rhythm, it's a normal sinus rhythm. What is a normal sinus rhythm? This is what can be asked of you. Normal sinus rhythm always begins at the SA node. So मेरा जो pacemaker है, that's at the SA node. It's going to travel via the internodal tracts into the AV node. There's going to be AV nodal conduction, जितना भी उसका delay होएगा, then it's going to conduct through the right bundle branch and your left bundle branch through the bundle of his. Then it's going to depolarize all of the myocardium via the Purkinje fibers. So that is my definition of the normal sinus rhythm. कि जो cardiac electrical activity travels from the SA node to ventricle via the SA node, via the AV node and your Purkinje fibers. So that is my normal sinus rhythm. Okay? So just remember, every P wave is going to be followed by a QRS. So that is my normal sinus rhythm. By what do I mean by the P wave? कि मेरा atrial depolarization हो रहा है and that is being followed by a ventricular depolarization with a PR segment. ठीक है? So this is my rhythm interpretation. And rhythm के लिए the best lead that I have is lead 2. So lead 2 is best for your rhythm interpretation. So regularity हमें check करना is very important. We can check the RR intervals and we want to check the PP intervals. So if both of them are regular, then I'm going to call कि मेरी जो rhythm है, that's going to be regular. अगर intervals कुछ भी differ करेंगे, then I'm going to label it as irregular. So let's just see how can we determine the regularity. So there are multiple ways about it. What I suggest you to do is I want you to carry a caliper. ठीक है, कैलिपर तो नहीं, बेसिकली वी कैन से जो डिवाइडर होता है इन योर कंपास बॉक्सेस, जो हमारा बेसिक डिवाइडर होता है, सो यू कैन यूज दैट डिवाइडर एज अ कैलिपर. एंड व्हाट यू कैन डू इज आप आरआर इंटरवल ले लो. आर इंटरवल एक आपने कैलकुलेट कर लिया, आपको कैलिपर फिक्स कर देना वहां पे, एंड देन यू कंपेयर द डिफरेंट आरआर इंटरवल्स progressively along the ECG. So that is one method. The simple crude method is the paper pen method. What is that? मैंने एक piece of paper लेना है and I'm going to mark the RR intervals over it. और ये मैं piece of paper है, I'm going to travel that piece of paper along it and measure different RR intervals as compared to it. मतलब basically जो मेरा paper है, that's going to function as a ruler. So that is the second method. Or obviously the crude method is your counting square method, just seeing how many कितना RR intervals कितने squares में है, but that's going to take a lot of time. So the main methods are your caliper method and your paper pen method. So you can use either one of them, right? So irregularity, as I told you guys, atrial arrhythmias or arrhythmias in particular, we're going to discuss it in some different section. Abhi ke liye just remember, irregular rhythm I'm going to see in something known as atrial fibrillation or in multifocal atrial tachycardia. Okay? When I'm going to say it's a regularly irregular rhythm, मतलब irregularities है rhythm में, no doubt, but they're occurring at a regular rate. So what is that? That is mainly your ventricular premature contractions. VPCs are occurring, वो हो रहे हैं एक regular rate पे हो रहे हैं, but that's going to lead to an irregular rhythm. So that is known as regularly irregular rhythm. So that is your VPCs. So heart rate calculations basic. ठीक है, guys, it's very easy. I'm going to say एक बहुत simple सा method. What I want you to know is, so if I see an R here, this is my R here, and this is my R over here. How I'm going to calculate that? कि मैं कैसे calculate कर सकता हूँ? There are two methods. I can say, let me just count the number of big squares. I'm going to draw 300 divided by the number of big squares. उसके कारण मुझे मेरा rate मिल जाएगा. That is one way of doing it. Or I can say, I can draw 1500 divided by your RR interval in your number of small squares. That is one way about it. There are two ways. ये तो simple हो गए. The method that I want you to follow, that's considerably easy, is very simple. What is that? अगर मेरे दो RR is separated by a large box, is going to get separated by a single large box, the rate is 300. Okay? If it's going to be separated by two large box, it's 150. If it's going to be separated by three large box, it's 100. Can you see? 300, 150, 100, then you can go 75, then you can go 60, and then again you can go 40. So this is how I calculate in a rapid way. Okay? I'm going to see an ECG and then we're going to calculate the heart rate together via this fashion. So this is the heart rate calculation. 1500 divided by a number of small squares ka RR interval, or you can say 300 divided by a number of big squares RR interval. So that is your basic heart rate calculation. So let's just move on to the different waves that we have. The first wave that I'm going to share with you is a normal P wave. Okay, so what is a normal P wave? So let's just see the criteria behind it. a normal P wave हमेशा is going to be less than 3 millimeters small squares broad. ठीक है, or I can say less than 110 milliseconds. Actually 3 will come out to be about 120 milliseconds. It's less than 110 milliseconds. So that is the first thing. What about the amplitude now? Amplitude will vary कि क्या वो chest lead है या वो limb lead है. I want you to remember the chest leads वाला. It is usually less than 1.5 millimeters, and limb leads में it is usually less than 2.5 millimeters. Very very important. Just remember this fact. ठीक है, very important. So let's just see what is right atrial enlargement, what is left atrial enlargement, and how we can diagnose it on an ECG. For detecting your enlargements, I want you to look at two leads in particular. I want you to look at V1 and I want you to look at lead 2. That is simple. So let's just see what will happen if there is a right atrial enlargement. So मेरा ये right atrium है, this is enlarged, and this is my left atrium which is smaller. So this is right atrium, this is my left atrium. V1 is somewhere over here. It's a right facing lead, right? And what about my lead 2? Lead 2 is somewhere over here. ठीक है, ये मेरा lead 2 है. I know this is in a frontal plane, that is in a horizontal plane, but just for simplicity, I'm going to draw it like this. अगर मेरा right atrium enlarged है, so I'm going to call it as right atrial enlargement, or it could be right atrial hypertrophy. इसके कारण some electrophysicians would like to call it as right atrial abnormality. So we can't say whether it is enlargement or whether it is your right atrial hypertrophy. Whatever be the case, what's going to happen? Usually मेरा जो vector था वो कैसा था? The vector was somewhat like this. ठीक है? But because the right atrium is very enlarged, what's going to happen is ये vector थोड़ा सा यहाँ पे shift हो जाएगा, और it can go shift over here as well. थोड़ा ज़्यादा shift हो जाएगा. तो दो चीजें मिलेंगी मुझे. What is that? The first thing is V1 में I'm going to see usually क्या होता है, V1 is a biphasic thing. ठीक है? So the initial part of it represents the right atrium, the later part of it represents the left atrium. Because left atrium के accordingly तो वो दूर जा रही है ना V1 से. So this is my normal V1. Usually they are less than 1 millimeter positive or negative reflection either of the right atrium, left atrium. So it's a biphasic reflection. But अभी मुझे right atrial enlargement में क्या मिलेगा is I'm going to see a predominantly positive wave in V1. Predominantly positive P wave मिलेगी in V1. So it's going to be more than 1 millimeter positive deflection I'm going to see in V1. So that is diagnostic of a right atrial enlargement. What about lead 2 then? अब lead 2 में क्या होता है guys? Because right atrial is considerably enlarged. So lead 2 में I'm going to see something known as P pulmonale. What is that? P pulmonale का मतलब ये है because it's moving from the right hand side towards the left hand side and it's moving from upwards towards downwards. So it's technically moving in the direction of your lead 2. इसके कारण lead 2 में amplitude मुझे बड़ा मिल जाएगा. कितना ज़्यादा? More than 2.5 millimeters. It's going to be a tall P wave. So it's going to be a tall tented P wave I'm going to see, and that is known as P pulmonale. Why is it known as P pulmonale? Because ज़्यादातर patients ये जो होते हैं, they are usually of core pulmonale or something like that or COPD. इसके कारण because right atrial enlargement उन्हीं patients में होता है, that is why it's known as P pulmonale. ठीक है? So let's just see what did we discuss. Right atrium में lead 2 में it's going to be more than 2.5 millimeters, and lead 1 में if the positive reflection is more than one small box, then I'm going to say that's right atrial enlargement. What about left atrial enlargement now? So the opposite will happen over here. So if this is my right atrium, smaller, and this is my left atrium, which is bigger. So what's going to happen? मेरा जो पोटेंशियल है वो कैसे ट्रैवल कर रहा था, ऐसे यहाँ से आ रहा था, ऐसे नोड से, एंड इट वाज ट्रैवलिंग लाइक दिस, है ना. बट अभी क्या हुआ, दिस इज इनलार्ज कंसिडरेबली. सो इसको भी तो डिपोलराइज करने के लिए कुछ टाइम लगेगा. सो द फर्स्ट थिंग दैट आई एम गोइंग टू सी इन लीड 2 इज, ज्यादा पॉजिटिव की बात नहीं है, बट लीड 2 में आई एम गोइंग टू सी अ ब्रॉड पी वेव. ठीक है, ब्रॉड पी वेव. ठीक है, मोर देन 110 मिली सेकेंड्स का. और द कैरेक्टरिस्टिक थिंग दैट वी ऑलवेज वांट टू सी is a bifid P wave. So this will represent your right atrium, this will represent your left atrium. This is a bifid P wave. But just remember guys, whenever you want to diagnose a bifid P wave, which is known as your P mitral, I want you to look at these peaks. These peaks should be at least more than one small box separated. एक small box separation इनमें present होना चाहिए. That is the reason तभी हम उसे P mitral कह सकते हैं. The second thing that I'm going to look at is V1. V1 में क्या होएगा, because left atrium is getting enlarged, so इसके कारण सारा पोटेंशियली इसकी तरफ खींच लेगा. देन V1 में जो मुझे बाइफेजिक मिल रहा था, अब क्या मिलेगा, स्मॉल पॉजिटिव एंड अ डीप नेगेटिव नाउ. सो इट्स गोइंग टू बी मोर देन 1 millimeter नेगेटिव डिफ्लेक्शन आई एम गोइंग टू सी, टर्मिनल वाला. So this is the criteria guys. So right atrial enlargement में lead 2 में more than 2.5 millimeters, this is known as P pulmonale, and V1 में positive reflection is more than 1 millimeter. What about left atrial enlargement? It's a broad, either it's a broad P wave more than 120 milliseconds, some books say it as more than 110 milliseconds, or it is more than one small box positive in amplitude or negative in amplitude. So that's your left atrial enlargement. So LAA and RAA का हमने basically वो कर लिया है. So there are two indices as well. So let's look at left atrial enlargement. Lead 2 में क्या मिलेगा? I'm going to see a bifid P wave with more than one small square between the two peaks. ठीक है? That is the first thing. or the total P wave duration is more than 3 small squares, that is more than 110 milliseconds in your lead 2. The third thing is Macro's index. What is that? Macro's index is P wave duration divided by the PR segment. Because the P wave duration has increased, as we saw, कि broad P wave मिल रहा है हमें, total P wave duration बढ़ रही है, इसके कारण this Macro's index comes out to be more than 1.6. So that is again diagnostic of your left atrial abnormality, guys, not enlargement, not hypertrophy. V1 में how can I diagnose it? कि मेरा first thing negative portion is more than 1 millimeter, and if I couple it with the fact that it's broad, जो negative portion है more than 40 milliseconds broad है, उन दोनों को अगर मैं multiply कर दूं, then I'm going to see the Morris index. So Morris index more than equal to 0.04 is also diagnostic of your left atrial abnormality. What about the right atrial abnormality? Lead 2 में I'm going to see tall more than 2.5 millimeters pointed P waves, which are known as your P pulmonale. And this is the thing, normal. This is your bifid deflection in your V1, and this is usually less than 2.5 millimeters. If it is more than 2.5 millimeters with the positive deflection more than 1 millimeter, then it's diagnostic of your right atrial enlargement. If it is left atrial enlargement, how do I diagnose it? I'm going to see a bifid P wave with more than 40 milliseconds का gap between the P waves, or it is broad by more than 110 milliseconds. And what about V1? V1 में if the negative deflection is more than 1 millimeter. And अगर दोनों की मुझे findings मिल रही है, tall भी मिल रहा है, broad भी मिल रहा है, negative deflection भी ज़्यादा मिल रही है, positive deflection भी ज़्यादा मिल रही है, then obviously it's a biatrial enlargement, ठीक है, or hypertrophy or abnormality. So this is so guys, जो भी सारी ECGs which we are going to interpret together, all of them are picked up from a site which I wanted to recommend. That's known as the LITFL, that is living in the fast lane. तो सारी की सारी जो वहाँ पे ECG का section है, that is fantabulous. वहाँ पे सारी की सारी even from basic things you can see pretty advanced things over there as well. So सारे के सारे जो भी examples हैं, they're taken from that. So let's see. Example 1, left atrial enlargement. How I can see that? Can you see the P wave, guys? P wave is broad. It's more than 110 milliseconds. Obviously, it's 3 small squares, so it's more than 110 milliseconds. Okay? And in दोनों के बीच में peaks देखो, guys. They're more than 1 millimeter. They're more than 1 small square apart. So it's a characteristic case of a left atrial enlargement. Okay? What about the next one? We can see right atrial enlargement over here. Can we see the P wave? P wave कितनी tall है देखो. Obviously, it's more than 2.5 millimeters, है ना? And let's look at V1 now. Okay, इसमें इन्होंने V1 दी नहीं हुई है. So it's right atrial enlargement. Why? This is known as P pulmonale. That is tall pointed P waves more than 2.5 millimeters in your lead 2. Alright. So we're going to continue rest of the session. We have covered about 50 slides over here. So जो next session होएगा, we're going to conclude our session in the next one. थोड़ा आज I think थोड़ा ज़्यादा time लग गया because we were delving into physiology as well. जो proper हमारा P wave आज हमने basically करा क्या है? We have discussed the basic orientation of the different cardiac axes of the different cardiac vectors. First thing. The second thing that we did today was about the lead placement, whether it be the generation of your unipolar chest leads, unipolar augmented limb leads, as well as your bipolar limb leads. And हमने वो पढ़ा भी, how are they augmented, कितना are they augmented, and what are the arrangements in the frontal plane or in the horizontal plane. And we discussed about the normal P wave. ठीक है, what is the normal P wave? उसके duration क्या है, उसका amplitude क्या है. How I can say that it's right atrial enlargement, how I can say that's left atrial enlargement, and how there can be biatrial enlargement, और वो मैं कैसे diagnose करूँगा. ठीक है. In the next session, let me just give you an overview. हम next session में क्या क्या cover करेंगे. So the next thing we are going to study about the PR interval. ठीक है. Because the PR interval का shortened PR interval का एक common cause is your WBW syndrome, that is Wolff-Parkinson-White syndrome. So we're going to diagnose that as well. ठीक है. And then we're going to discuss about your prolonged PR interval in the form of your junctional bradyarrhythmias or something known as your heart blocks. So we're going to see for first degree heart block, we're going to see second degree heart block. Second degree means we're going to see the different 3 types of second degree heart blocks, and then obviously the complete heart block, that is your tertiary heart block. Then we're going to discuss about the QRS nomenclature. What is a Q wave, what is a R wave, what is a S wave? Because things might not be simple. You might have heard terms like R, R prime. You might have heard some things like कि जिसमें हमें quadriphasic potentials भी मिल सकते हैं. उन situations में what is a Q wave, what is a R wave, what is an S wave, वो हमें कैसे पता लगेगा? By studying the normal QRS nomenclature. Then we are going to discuss something about something known as technical dextrocardia and how we can differentiate it from your proper dextrocardia. ठीक है, वो भी हम discuss करेंगे. Then we are going to discuss about your normal R wave progression. हमारा normal R wave कैसे progress करता है on your precordial chest leads. Then we are going to discuss about the normal QRS complexes, and then उसमें we are going to discuss a very important thing, that is the permanent footprints of your MI. That's a pathological Q wave, and how do we interpret it and what is significant for us. उसके बाद we can talk about, obviously we can discuss about right bundle branch block. We'll be discussing things about left bundle branch block. We'll also be discussing and delving into details of your hemifascicular block, that is left anterior fascicular block or it is left posterior fascicular block. हम वो भी discuss करेंगे. We're going to discuss left ventricular hypertrophy, right ventricular hypertrophy, and how are the different scoring systems or the different criteria that we use for RVH and LVH as well. उसके बाद we can focus our attention on to your ST segment. What is ST segment elevation? कितना significant? What is ST segment depression? कितना significant? What is the localization and what are the different morphologies of it? We're going to discuss something about the causes of ST segment elevation और वो हम कैसे differentiate कर सकते हैं. How is STEMI different from your acute pericarditis? How is acute pericarditis different from your benign early repolarization, that is BER? वो भी हम discuss करेंगे. We're going to discuss something about the QT interval and how we calculate the QT interval and how do we compare it, what is the normal range in males and females, and we're going to discuss something about the Bazet formula as well. And then obviously we're going to move on to the main thing, that is your changes in an MI. So what are the different changes that happen over the course of an MI and how do we diagnose it and how do we localize it? How we can localize an MI on the basis of the different changes that we see on an precordial chest leads or whether it be on the limb leads. So we're going to discuss all of that in the future lecture, guys. So and obviously this is a series of lectures that I'm going to have on ECG. So आज हमने basically 40 slides cover किए हैं. The rest 60 odd slides you're going to cover in the next session. And for subsequent sections, we're going to discuss something about the arrhythmias as well. How do we diagnose an arrhythmia? How do we treat an arrhythmia? Okay. So obviously उसमें हमें थोड़ा anti-arrhythmic drugs you can meanwhile watch on CVS pharmacology. हमने already CVS pharmacology we have covered in 2 videos. हमने 2 videos में पूरी CVS pharmacology cover किया, so you can refer to that as well, right? So I just believe I think today was a good session, and I hope that you enjoyed it, and I hope that you learned from it. And just remember, guys, whenever you are on to your wards, whenever you are examining a patient, if it has an ECG lying over there just like that, don't ignore it. Just read it. Just try to interpret it, right? If there is any problem, if you are at a thoda sa, okay, if you don't think that you can diagnose it, कोई problem आ रही है, you can always message it to us कि ये ECG है and how do I go on about reading it. ठीक है? So पहले we need to be familiarizing ourselves with the conceptual part of it. Then obviously we can determine how do we look at an ECG and what are the different things that we can say. So हम basically sample videos, sample ECGs भी attach करेंगे in which we'll go together. I'm put together by my own patient, which we have seen in the ward. I'm going to send those ECGs to you as well, and we're going to have these sessions regularly and just be done with ECG in a proper fashion. So I think I'm going to close this session today, and I hope it was good. So you can give me a thumbs up and just see whether you are sticking at the end of the session. And all of these videos are going to be stored at the end. So you can watch it at a convenient time that you want. You can watch it at 1.5x. Okay? So 50 minutes ke session mein we covered about 50 slides. I think that's a win for us. And next May we're going to be done with the basics of ECG and localization of MI. Whatever that is left will be your arrhythmias. Arrhythmias ke liye I need a separate lecture in which we can go over the different arrhythmias that we have. So I'm going to close this session today. I thank you all for joining, and I'll see you in the next one.